Good evening, and thank you for joining us. I'm Deborah Livingston, and I am the Development Director with the Mayfield Education and Research Foundation. Welcome to our next installment of Spine Talks, our webinar series created to improve your spine health. We are picking up this evening after November's webinar, where we learned about treatments for an abnormal spine. Tonight, we are joined by Dr. George Mandybur here at Mayfield Brain and Spine. Dr. Mandybur will help us gain a better understanding of how spinal cord stimulation can treat chronic pain. Thank you, Dr. Mandybur, for being here with us this evening. Dr. Mandybur is a neurosurgeon here at Mayfield Brain and Spine and a great friend of our foundation in serving on our board. Thank you for being here, Dr. Mandybur. You may now begin your presentation.
Well, thank you very much for that introduction, and thank everyone for joining in on this quite important topic on how to treat chronic pain, mostly back pain. With the first slide, I want to talk about just pain in general, and this first slide is depicting kind of like how we're going to sort of talk this evening. So talk about chronic pain, then talk about medical management and some issues there. What is failed back syndrome? And then we'll end up with spinal cord stimulation. So with regards to pain, chronic pain particularly, we can dissect this into two separate portions. Acute pain, which is something, say, like you stub your toe and you have immediate pain, versus chronic pain is, something that's been bothering you for a long time. Usually the acute pain is a sudden injury that, like you cut yourself or, something hits you, versus chronic pain is something that's there, not necessarily a direct injury from the very beginning. So acute pain typically will last for a short period of time. Chronic pain obviously lasts a longer time. We usually say several months. Here it says 3 months. Even the processing of the nervous system is a little different with regards to acute pain and chronic pain. Pain signals in the acute state may be more accurate in telling you that there is acute tissue injury, i.e. a cut or a burn, where chronic pain is where you're feeling a lot of pain, but there's not a lot of immediate tissue injury occurring. Say like arthritis in the shoulder or something like that. When you move your shoulder, it doesn't mean you're constantly creating a lot of injury, it just hurts a lot. With regards to chronic pain, everybody's a little different, and how people react to, say, that chronic shoulder pain or chronic back pain can be different, and emotions can play a pretty big role in how you perceive this pain. Some patients, they say they're pretty tough, and then they have a lot of chronic pain, and they can actually do pretty much their activities of daily living without much problem. And some people will have some pain and they catastrophize. They feel like it's the end of the world, a little bit of pain, and they start feeling like, oh, I'm gonna have to live with this for the rest of my life. And they feel like it's such a big part of them, yet they still have full neurologic function. Their legs work, their arms work, they can still get up and move around. With regards to chronic pain, we dissect this in two basic categories, as we call nociceptive or simple bone muscle joint pain, or neuropathic pain is something specific with nerve injury. You can have one or the other or a mixture of both. It's up for the physician to kind of figure things out. But typically nociceptive pain is, aching, localized, say, to a joint. So you move your hip and the hip hurts, you move your knee, the knee hurts. Where a neuropathic pain tends to be more in the distribution of a nerve. So a shooting, burning, tingling, numbness, maybe even some weakness associated depending on the nerve itself. Nociceptive pain can involve something like the belly or in stomach areas and some stuff that's going on in there. That's a special type of pain called visceral pain. And with regards to pain centers, on the nerve pain, if there's damage to the nerves somewhere along the line, it can cause pain itself. Second. There's a thing called the pain cycle. And this is kind of important because both the physical and the psychological issues play almost equal roles, if not maybe, you know, everybody kind of thinks about the physical with regards to pain, but there is a very strong psychological component, and you can't completely dissect one over the other. When we think of physical pain, so you have some pain and then it bothers you, it keeps you from moving around, you become deconditioned, so you become weaker. Because you're weaker, you can't move around much, but then you have a bad mood, and the bad mood makes you depressed, and then that depression itself can actually work on your nervous system to actually increase your perception of pain. So the pain becomes more important, as it were. So you can see how these two cycles kind of can really wind each other up with regards to the if you have the depression, you feel bad, you become less active, you become more deconditioned, and then you can see how everything can kind of increase the pain overall. And this is actually very important because when we're dealing with chronic pain, we cannot forget one or the other. We have to treat both. Chronic pain is a huge thing in the United States. It's, you know, hundreds of billions of dollars in lost productivity, lost wages, work days. You know, it's, you know, 25% of Americans suffer from some kind of chronic pain, you know, headache and back pain being the two biggest ones. And it accounts for almost 80% of all doctor visits. Now, when you go see the doctor, most of the time what they give you is pain medication. They may first start out with something like a Motrin or something that's non-narcotic, but then eventually as chronic pain builds, they may start prescribing narcotics. And now this has become a national problem because narcotics have kind of found their way outside the medical community, and there is a definite abuse issue going on nationally. And so the prescription of opioids has really become very scrutinized, both on the federal level and the state level. And you can kind of see by this map, yeah, it's a little outdated at 2015, 2016, but you can see Ohio's, you know, had a big problem back then, and it's still a big problem nowadays. And over the last year, everybody knows this problem we've had with the COVID, and it's causing emotional turmoil. And now we can see, as you see these graphs, so the first set of bars is all drug abuse deaths. And you can see how it's just exponentially increasing since the beginning of 2020, and right around the time when COVID started. And you can see how, you know, people start, they don't feel good, they depressed, they take medication, they don't think about it. Some of these drug overdoses are non-intentional, but they don't know what they're doing. So is there some other way we can treat these patients without needing all this medication? There is a treatment continuum that we use. So patients who have, say, chronic back pain, you know, typically we want something, you know, more conservative, less invasive first, and patients prefer that. So if you give a pill and the pain goes away or is very well controlled, that's appropriate treatment. If it's not helpful, then you try some physical therapy. If that also is not helpful, then maybe we can go a little bit more interventional and do something like an injection or numb it up or an epidural steroid or something like that. And sometimes that's enough to kickstart the patient into the right direction. They don't need to go any further. If that doesn't do the job for taking care of the pain, then surgery or surgeries of different kinds can be entertained. So say you've had the chronic pain and you've went through that and you had a spine surgery, more traditional. But then say 6 months, a year later, you still have pain or the pain has returned. This becomes labeled as a failed back surgery syndrome. It is a bit of a misnomer because what's really going on is not so much a failed surgery syndrome, it's the underlying problem going on in the spine. Surgeons cannot completely fix the underlying problem. We can't go in there and give you a new disc or a new joint or new spine bones. We kind of have a bad situation there with a herniated disc. It's like a defective part. It's degenerated, and we try to minimize its impact on the nerves. Sometimes the joints are bad too in the spine, and then we minimize that by doing a fusion. But they are not the natural state of the spine, and so that in and of itself can cause trouble. As we look at the numbers, up to 40% of lumbar spine surgeries can not be successful in the long term, and patients will be referred back to the spine surgeon to discuss, well, what else can be done should they have further surgery. And this becomes controversial, and then you start talking about social and psychological issues start to throw in there. And it is known that if you have chronic pain, that it does wear on your emotions, and then that becomes a bigger player. And even if everything seems to have gone well surgically, things still may not go well because we forgot not to treat other problems that may be going on with the patient. You're a whole human being, not just a spine. So what about more surgery? We can do from a simple laminectomy to fusion procedures, and they can be quite extensive. And as you can see from this X-ray here of a lumbar fusion with pedicle screws, which a number of times can do quite well, but these are complicated procedures and can have problems, and you're not going to be immediately pain-free after the procedure. So after all of this, we can talk about spinal cord stimulation. So what is spinal cord stimulation? It's basically an implant that can be removed anytime. Think of a heart pacemaker, but put into your spine, right into your heart. And this device, what it's doing is, we say here masks, and that's a simplification of what it does, but it actually modulates the nervous system, and it helps with the nervous system dealing with these chronic abnormal signals. So you can think of chronic pain as the nervous system has learned a wrong signal, and this is trying to modulate it back into a better signal. And this is a depiction of what we believe is going on when we do spinal cord stimulation. So this is called the gate theory, and it's a pretty good theory, and it's been kind of worked out. The actual, what we believe nowadays, it's a little more complicated than that, but it still follows the same rules. Is what the stimulator is doing is it's able to kind of overdrive, shut down the bad inhibition, the bad signals. One thing that we're noticing, so the spinal cord stimulator is a relatively easy procedure to perform, and spinal cord stimulation has been around for quite a number of years. So the first stimulator implanted was late 60s, became popular in the 80s and 90s, and recently really became popular with newer, easier technologies. Be that as it may, this is a study that looked at patients who have had surgery and continued to have back pain and leg pain. The number here is 16,455 patients were found. Of these 16,455 patients, who got further surgery? 16,060. How many of these patients got spinal cord stimulation, only 395. Well, it's not to say that half and half should be there, but this is almost a 40-to-1 ratio with the lumbar surgery and spinal cord stimulation. When we look over to the right side, we have matched patients. So 222 patients, 111 with spinal cord stimulators and 111 who had lumbar surgery of one type or another. They pretty much were even with regards to outcome. And so it kind of bodes the question is that why are we doing so much more lumbar surgery when the outcomes aren't any better than with the spinal cord stimulation for the most part? And if we dissect this thing even further, we can look at and see, well, what about problems after surgery? So if we look at lumbar reoperation rates versus spinal cord stimulators, so SCS stands for spinal cord stimulation, and the p-value means statistical significance. So if you see those numbers, all of this is statistically significant. So if you look at complication rates, day of surgery, 30 days after surgery, 90 days after surgery, it's 2 to 3 times more prevalent in the reoperation procedures than it is in the spinal cord stimulation. This is pretty much because the spinal cord stimulator is a more minimally invasive, simpler procedure to perform. So we can also look at spinal cord stimulator as opposed to just medical management. So there's a big study called the process study. So here on the left, you'll see the process study where they looked at 100 patients that got either spinal cord stimulation or medical management. And these patients were really watched closely, so they probably got really good medical management. And they looked at who got 50% pain relief or better. Well, what we saw was this 47% of those patients who had spinal cord stimulation got better than 50% pain relief. Only about 7% of the medical management got better than 50% relief. Now, to the right side, this is talking about spinal cord stimulation versus repeat surgery. And I briefly was alluding to this earlier. This was called a North study. Dr. North performed this study out of Johns Hopkins some years ago and looked at, it was just 50 patients, and they looked at whether you had spinal cord stimulation or lumbar reoperation. And this was lumbar fusion, I think, were most of these patients, and who got better than 50% pain relief. And they had significantly more spinal cord stimulators with good result as opposed to surgery. And this was a crossover design study. So patients who had surgery could eventually go over to the spinal cord stimulator, and the patients who had spinal cord stimulators and didn't do well could go over to the surgery side. And a vast majority was in favor of spinal cord stimulation as opposed to going to surgery. So the overall goal of the spinal cord stimulation therapy, I mean, basically it's to help the patient have good pain control so they can be more active. So what it's doing is with the electrode in the spine, and you can see this, the moving arrows is, think of that as pain transmission to the brain. And then you can see the, there you go. And then you can see, and then you can see the spinal cord stimulator device there, and it's interfering with the transmission there. And the idea is to reduce medications and help the patient function better by getting up, moving around. And kind of like with our pain cycles, if I can get patients to move around more, they become less, they don't feel so bad. They feel like they're a little more interactive with people. So they, things start to get better rather than get worse. And that's kind of where we want patients to go. So who can be a candidate for spinal cord stimulation? So a lot of this also parallel repeat surgeries, say conservative therapies, during our continuum aren't working, and say patients don't want to go for additional surgery or they're not a candidate. There's nothing for the surgeon that he's able to do. And so they can go to spinal cord stimulation. Some patients just don't want to go under a big surgery. So some patients will be offered, say, a long arm spinal fusion, and they're afraid of it, higher complication rates, so they can at least try spinal cord stimulation first. So those are potential candidates. Medical conditions may also keep you from having a procedure, and since this is an outpatient procedure, and it maybe takes an hour or two to do, you're not under a lot of anesthesia, and there's not a lot of blood loss. So relatively ill patients still may qualify for this, where they may not qualify for a larger spine surgery. So that's something else to take into account. So if there are underlying psychological issues like depression, drug addiction, or such like, these things, like I said earlier, the whole person needs to be taken care of. I can't just, dissect out it's just the spine and only the spine, and if I fix that, everything else gets better. It rarely works so simply. Other things that we do is we do a spinal cord stimulator test. So this is what we call a test drive or a test trial of the spinal cord stimulator. This is something somewhat unique in this procedure where you can sort of try it before you buy it. It's kind of like test driving a car. You can see if this thing seems to be your cup of tea. In addition to that, we can also now help choose from a wide variety of different formats with regards to stimulation. So over the decades, there's been a lot of research with how the nervous system is being interacted with these devices, and we're finding more and more that different settings within the stimulator will affect the nervous system in different ways. Most of them are beneficial. So some patients like a sort of a massaging, tingling feeling. So it'll be over on the left side. But more and more we're finding, especially with the newer technologies, we call paresthesia free, where patients really don't feel the stimulation. And so, but they still get the pain relief. Kind of like taking a pill. You don't feel the pill working, but you feel the relief. There are numerous devices that are available now. These are 4 companies that we work quite frequently with. They're pretty much nationally recognized. They are the big 4. There's some little guys that are out there trying to make their way into this realm with some new interesting technology, but they're still kind of just getting started. You can have a discussion with your physician, pain doctor on which one, if you know which one or which one they're interested in. And each one has its certain benefits, so it's something to discuss. I'll talk a little bit about it, but I'm not going to talk about any particular brand here. Also, with regards to the trial and the surgical implant, we have a variety of the little wires that we put into the spine. Some are long, thin wires, and some are flat paddle-like wires. And some have different configurations within that paddle lead. And it kind of depends on what kind of pain the patient has, where the paddle or the wire needs to go. So is it the lower spine, the middle spine, or even in the neck, we'll put these things in. And what does the screening MRI look like? How much room is in there? These are things for the surgeon. And now that we have lots of variety, there's, it's almost no place that we can't put these things in with the variety of electrodes that we have. Another thing that we can talk about with patients is you have a choice between we call primary cell and rechargeable, these batteries. IPG is implantable program generator. Excuse me. but we call them batteries. That's for a simpler term. And the primary cell battery is basically a simpler system for the patient to use. You really want a lower power requirement, but with some of the new technologies with those frequencies that I was talking about earlier, they can be quite viable. They tend not to last as long as the rechargeable batteries, but the big benefit there is it's much easier to deal with. You don't have the extra hardware to deal with the recharging every so many days, however you need. But the advantage of a rechargeable battery is that the battery will last you 2 to 3 times as long as a non-chargeable battery, but you have to charge it. And so some people find that that becomes an issue, and then sometimes they just get fed up with charging if it's a bit of a problem, and then they stop charging and the battery dies. And so I would say majority of patients now are still going rechargeable because they are small batteries and the charging isn't too bad, and the batteries will last you up to 10 years. The primary cell batteries, it's hard to say exactly how long they will last, anywhere from 3 to 5, 6 years. That depends. In addition to the implanted hardware, you'll also have some outside hardware you'll have to use. To the left, you have the patient remote. Different companies have different variations, but basically this is like a remote control for your spinal cord stimulator. You can turn the system on and off, turn it up and down, or flip programs. Just make sure you don't mix it up with your TV remote. You have a charging unit. You can see that this one has a pad. The pad will be placed over where the battery is implanted, and through the skin can easily charge the battery. If some of you have seen those pads where you can put your cell phone on and it will charge just by laying on it, it's a similar technology, and it's usually pretty easy. Most charging times are an hour or less. So I talked earlier about the test drive, and this is kind of like a really nice thing about the spinal cord stimulator, to try it before you buy it. So this is the technique for it. For those of you who are familiar or have had personally a epidural steroid injection, I would just call this a fancy epidural steroid injection. So it does use needles. They use the fluoroscope. It's done as an outpatient, and usually the same physician who does epidural steroids can do these trials. So what is done is they take these needles, just like in the epidural steroid, they put them into the spine, and rather than injecting the medication, they thread wires up into the spine area where these need. This can be done under light sedation, but a lot of times what's happening is just like in the epidural steroids, you know, the area is numbed up, so you really don't feel a lot, and then you'll feel just the pressure. And then after the stimulator is in place, they'll actually turn it on, and you'll actually see or feel what it is. So here's a depiction of our doctor doing this trial. You can see how the wire is just nicely going up into the spine, just snakes up in there. He can kind of wiggle it around to get it into the right spot. You can see him twisting the wire. So there'll be things like adhesions or scarring that he has to go around, and that twisting kind of helps him get around it. He'll tie it down and hook it up to some wires. These wires will be hooked up to a transmitter, and then you'll see here in a minute here. So these transmitters will be talking to the computer. The representative can throw in some programs, and then you can flip through programs after you go home and kind of test drive the system and see what works for you. Typically, the trialing will last several days, anywhere between 3 to 7 days. We usually like to have patients keep a pretty detailed log of what kind of activity you're doing, any changes, what's going on. Are you sleeping better? You know, taking less pain medication, things like that. So say you've done a week trial and you noticed you had sleeping better, you didn't feel like you had to take as much medication, you could walk the dog, or you could walk to the mailbox or something like that, where before you couldn't or had a hard time doing, and you thought, oh, okay, this feels better, I want to go ahead for the permanent. Those temporary wires that the other doctor put in will be removed because they're only temporary. They're not meant to be in there permanently. Then you'll be sent to the surgeon, and then the surgeon will see you and discuss the details of the surgical implant. You can see the actual device and how it's done. So it is a surgical procedure. Nowadays, we do a lot of patients in the asleep method. There'll be an incision about an inch, inch and a half in the middle of the back. There'll be also another incision, inch, inch and a half on the side. Typically, it will be close to what I call the back pocket position. So think of your pants. If you had a back pocket, where would that back pocket be? And that's usually kind of where under the skin we'll put the battery. Now, mind you, the batteries are small. They're about the size of a ladies' compact, something like that. Maybe just about an inch and a half in diameter for the most part, and maybe half a centimeter to a centimeter thick. So they're not too big. They're smaller than most people's wallets. So, and you hide it under the skin, it's usually pretty good. All wiring, everything is under the skin. There should never be any wiring sticking out after a permanent implant, and you should never see any part of the device ever. Wounds are closed. Like I said, this is an outpatient procedure, so you usually are woken up, and then after you wake up, walk around, you go home. Now, in general, there are two techniques with regards to the permanent implantation. One is the more traditional, where we wake patients up in the middle of the procedure, turn the system on, and check and make sure that it seems to be good. In the more newer asleep method, we completely sedate the patient with general anesthesia this time, and we do put in the electrodes, and a lot of times we're doing x-rays on both the asleep and the wake and make sure that the electrode looks like it's in a good spot. But also what we do is intraoperative neuromonitoring, sort of nerve-evoked monitoring for the spinal cord stimulator. And with the patient asleep, we do have methods that we can test the patient, so I don't have to wake patients up. So they're completely asleep for the entire procedure, and both surgeon and patient seem to prefer this. And it doesn't take any longer to do it this way versus the other way. And this is a newer procedure in the last several years. I have adopted this over the last 3-4 years myself, probably done 100 or so cases like that. Everybody seems to be doing pretty well, and I don't see any obvious drawback. Advantages, obviously, it's more comfortable. You don't have to be woken up, and any issues there. Since the patient is less likely to move, it's easier for us to implant the device. And with regards to anesthesia, we believe the general anesthetic, the sleep method, is actually a little safer than the awake method. The disadvantages are somewhat relative, and they're not panning out as we look at data of this newer procedure. People will say, well, you can't turn on and double check and make sure that the tingling is in the right spot. Well, nowadays that is less important because we use no field stimulation a lot, so that's not as important in that respect. But we also have this neuromonitoring method that helps align the electrode with regard to the spinal cord and nerves, where we don't have to wake you up, and that's panning out pretty well. So back to this method of neuroevoked monitoring, I really like this method because it's been shown to be safe, effective. It's almost standard of care with most spine surgeries now. So if you had a cervical disc surgery or a more extensive lumbar surgery, it's very likely that this procedure was done as well, just for monitoring. But what we're doing in spinal cord stimulation is not only monitoring, but I can test stimulate. And there are different ways of being able to do that. And basically, there are three of them. Here on the right side, you have three figures. At the top, you'll see MEPS, SSEP/DEPS, and then you have EMG. So these are three different ways that I can sort of test and make sure, one, everything is safe and good, and the other is it more right or left? Am I getting the right levels? So this is a picture showing you where the incisions would be roughly. They are slightly altered for each patient, but this is pretty much the gist of it. And we mark it on the x-ray during the procedure, and we do a partial laminectomy. So we remove a little bit of the bone there. You can see, that's been grayed there. We remove a little bit, and sometimes more, sometimes less. It depends on what's needed, but rarely we need to do full laminectomies, like if we did a lumbar disc or something like that. Then we can implant the battery in the pocket area. All the wiring is underneath. You can't feel the lead itself. Sometimes you can feel the tunneled wire if you're thin. Batteries you'll be able to feel because they're pretty good size, and you need to kind of know where it is if you have a chargeable battery. So this is another side view depiction of the electrode placed in the epidural space and its ability to affect the spinal cord directly. And this is x-ray of the permanent implant. You can kind of see all those black dots are the actual electrode itself. Typically, we put in as many of these electrodes as we can. So each lead, some have 8, some have 16, some even have 32 contacts. A lot of times you think more is better, but it is almost never that we turn all of these on. More is kind of shotgun method, is that we're more likely to get the right spot by having more in there. Typically, patients will run maybe 1 or 2 programs, and each program maybe uses 4 or 6 of these black dots at a time. So when we're testing intraoperatively to make sure that the electrode is in the proper position, there are several different methods that I was using, and I kind of alluded to those earlier with those diagrams. As we turn up the power on the stimulator itself in the surgery to test its position, there'll be an evoked response. So the patient's asleep, they don't feel anything, but the nerves still are active. And so we can activate these nerves and then record from them. So it kind of depends on which nerves we're looking at on what we're going to see. So the first top we see here, the STIM, TR, EMG, that can help me tell right or left. And these are pretty accurate for the most part. We typically use 2 separate types of testing to verify position. And I would say about 80% of the time they're in agreement of saying that either it's middle or to one side or the other. The other method we call collision method. And this is kind of fancy, and maybe this is a little bit much, but I think it's really interesting on what the stimulator is doing to the spinal cord electrically. I mean, it seems to be a good thing. And this is how I can use this method to help determine that the stimulator electrode's in the right position. So we're done with the procedure, and then what happens afterwards? So like I said, generally it's an outpatient procedure. I would say 90% of the patients go home the day of surgery. We tell patients, you should be up and about, walking around, but avoid excessive bending, lifting, twisting for at least 6 to 10 weeks. Kind of depends on your healing rates. And the patient will come for follow-up within 2 weeks, and then we'll go over use of the device. Sometimes the device needs adjustment, tweaking, things like that, which is very common. Try to get patients to start doing light exercise. We get physical therapy involved as well early on to help you get back on your feet. Now, if every procedure, there is some potential complications, and we showed earlier that the complication rate here overall was somewhere in the 5-6% range. So what these complications can be, complications of laminectomy, even though that's limited, still can cause a problem. So bleeding, infection, spinal fluid leaks are possible. Lead migration, I would say, can occur. Used to be more frequent. Now we've learned some techniques to help mitigate that, but still occurs. That's where the electrode, with those black dots on X-ray. So say everything is looking great and something happens. So say, 2 weeks out, you trip over the cat and you have a fall. It's possible that could dislodge the electrode, depending on what's going on and whether we can replace it well or not. Over a period of time, epidural scar can become an issue where actually it insulating the electrode by just forming a scarred sleeve around the electrode and preventing a lot of the electricity coming out of the system to get to the nerves. Also, the device itself may have a problem. So a wire may break, or the battery itself may go bad. Or something happens with regards to where the battery is, for instance. So it may get sore, uncomfortable. We may have to move the position of the battery. So this is a bar graph of how patients do afterwards. And these are some of the more recent outcome studies. So we see isolated back pain relief, up to 67% of the patients had 50% or greater relief. Leg pain, better, up to 72% had better than 50% pain relief. So overall, the patients seem to have about a 70%, 70% of them had better than 50% pain relief. Now, there's a lot of new technology that's available now, and they're sort of testing, well, how good is the new tech versus the old tech? And this is some of the data that we're coming up with now. So you see traditional SCS. This is called HF10, but there are several other systems that are relatively comparable that use new programming parameters. And these are new technologies within the battery itself of what it can do. The surgeries have pretty much been the same. It's just the technology that we're implanting now is so much more sophisticated, it can do more. And we're seeing now with this new technologies, improvement even more so with regards to back pain and leg pain. And this is kind of getting back to what we were talking about earlier about medication use. So this is showing patients with spinal cord stimulation, the newer models are finding that patients not on opioids, 3 times the number of patients are off opioids than what they were on beforehand. And those who are on have a significant decrease in the amount of medication they're using. Now, I will also stress to say this is very important that the patient and the pain management physicians are working together with the goal of obtaining this. Unfortunately, many times I'll see patients who say they have a spinal cord stimulator, they were on a lot of medications, they did pretty well, they went home and they just were home, and they would periodically follow up, but nobody was really kind of addressing, well, should we decrease the medications and so on. It does take quite a bit of effort to do this, but it is so beneficial for patients to at least attempt and pursue the decrease in medications. It can help them tremendously. So not only they get better with the spinal cord stimulator for pain relief, but they also get off medications. And overall patient satisfaction, when you look at it, even 2 years out, patients who were doing well continue to do well. And, yeah, you always have some patients who don't like it. You can't fix everything. And sometimes, they need something else done as well. But this is a very good procedure. It's kind of on the lower risk side. And it's, insurances cover this. And now more and more physicians are aware of them. And then some patients will ask, well, it's a device, it's got a battery. Can I have MRIs and imaging done? Many of the systems that are available nowadays are MRI compatible, and you can have MRI, CT scans, almost anything. So if you needed something for something else, so say multiple sclerosis, you need repeat MRIs of the brain, it can be perfectly done. Okay, no problem. Okay, and I'll be ready for any questions if they have any.
Great. Thank you so much, Dr. Mandybur. Is this the HR-10 stimulation? If so, does Ohio Medicaid cover this cost?
For the Nevro HF10 is some of the stuff that I talked about, yes. Yeah, the Medicaid covers all of them. It's not specific for any particular brand. Okay. It's the hospitals that have the particular brands on their shelf.
If the remaining pain after spine surgery is piriformis muscle related, can SCS help here?
Well, for piriformis syndrome, it's not directly indicated, but I would say, and maybe in some patients, it can help. Piriformis syndrome, typically physical therapy is one of the better treatments.
Okay. What is the downside overall of spinal cord stimulation? Is there any?
Patients have to deal with an implant. So you have to charge the system, or just plainly deal with it.
Mm-hmm. Okay, so this certainly masks the pain. Does the underlying cause of the pain continue to deteriorate after the stimulator is implanted?
This much what I alluded to earlier, so including the regular spine surgeries, nothing really fixes the underlying problem, which is the degeneration of whatever it is, the ligaments, the disc, the bone, the joints. Nothing fixes that. So regular surgery doesn't fix that. Spinal cord stimulation doesn't fix that. It's just a matter of mitigating the pain, whether we remove an offending something pushing on a nerve, but we're talking about repeat surgery. So usually that's already been done, and that surgery has been done already. After that, then nothing really fixes the underlying degenerative problem. So yes, it does not fix the underlying problem, but what it does do is it allows the patients to become more active, and in that sense, makes the patient healthier.
Okay, how long does the stimulator stay in place?
The patient, the stimulator can stay in place forever, and it can be removed at any time.
Okay. Does charging your battery require the help of a family member or a loved one?
Usually it does not, but it does depend on the patient themselves. I would say 90% of the patients can do it easily by themselves.
Okay, great. I think that is our last question. If we see any more come through in the next sec, I think that's it. Okay, great. Thank you so much. That was wonderful, Dr. Mandybur.
You're very welcome.
I think that'll wrap up our Q&A. We hope you enjoyed tonight's presentation. This was the last program in the Spine Talk series. So we will begin a new Brain Talk series in February, on February 8th, with Dr. Yair Ghazal. Dr. Ghazal will help us learn more about when to seek treatment for headaches and other related symptoms. You may register for the Brain Talks program at any time and view all presentations on our website at mayfieldfoundation.org. Dr. Mandybur will join us again, I believe, in May to talk about deep brain stimulation as it relates to Parkinson's. For more information about Spine Talks, Brain Talks, or the work of the Mayfield Foundation, please visit mayfieldfoundation.org. And I'd like to thank you again for joining us and hope everyone has a great evening. Thank you.